Thank you very much. Can I have my slides? Okay. So no financial disclosures. I'll begin with having a look at the timeline of refractive surgeries. It started all with RKs. It was in vogue from about 1980s till about the middle of 1990s, following which LASIK took over and is still continuing. It started with microkeratome-based LASIKs, and now it's mostly femto-based LASIKs. ICL has been here since about 15 to 18 years, and then SMILE has been there. Why I show this slide is that when these patients underwent radial keratotomy, assuming they were at least 20 years old then, these are the patients who are now 60 or 70 plus and going to be presenting with cataracts now. And as we move down this list, the number of patients as of today will go down and down. So in my own OPD or practice, I see about 2 or 3 patients every month with previously operated refractive surgeries, and the ratios match this data. That I see about 2 RK patients for every 1 LASIK patient who has undergone some kind of refractive surgery who have come for age-related cataract now. I've yet to see a patient who has undergone SMILE and has presented with cataract. ICL, of course, we do see cases who need cataract surgery, but those are primarily who have developed cataracts because of the lens itself. The point of showing this slide is that these were the patients who were very fastidious about not wearing glasses at all, and had taken those risks at that time. They go in for neurosurgeries, so their risk appetite is higher, but so are their expectations, which have to be managed at the time of cataract surgery itself. Now, when we talk about post-refractive surgery IOL power calculations, there are 2 issues at play other than the psychology of the patients involved. It is the measurement of the biometry. The anatomy itself is distorted, so whatever instrumentation which we use, it works on some kind of assumptions, especially where keratometry goes. So when you do a laser-based refractive surgery like LASIK or SMILE, all those assumptions become invalid. And similarly, when a patient has undergone RK, especially if it has flattened and it is still going under a hyperopic shift, all those assumptions when we do keratometric measurements again become invalid. Primarily, all formulas have same weightage to various biometric parameters. If you have an error of 1 millimeter in axial length measurement, you will end up with around a 2.5 diopter error in postoperative period. Similarly, keratometric evaluation, if you have somehow you end up with a 1 diopter error in measurement of keratometry, then you will expect an error of 1 diopter post-op in the postoperative period. So I'll take out axial length out of the way first. We, in fact, did a study a long time back where we measured axial lengths after the implantation of ICLs, and we found that they make no difference in terms of axial length measurements. And regarding the laser refractive surgery, it works slightly differently, which I'll take up slightly in a later slide. Now, the problem with the keratometry is that it fails to accurately capture the central keratometry, especially in cases of previous refractive surgeries. Now, what happens is that it measures the paracentral points at 3.2 millimeter zone, and there is a flattening shift as you move towards the periphery. And the older generation biometers do not take this into account, and they also don't measure the posterior corneal surface, which has also been altered. So what happens is that if a patient has undergone a myopic LASIK, you will tend to overestimate the K and end up with a hyperopic shift, and you will underpower your lens. So if the power required was 20, you will probably put a 15 diopter lens if you go by the conventional methods, and vice versa for hyperopic LASIKs. So the other thing which I said, I'll come later, the axial length measurements. So they may not directly affect the axial length, but they do affect the effective lens position, which is actually taken into account with the newer generation formulas. So now we have come to two sources of error. One is the primary inaccuracy in measurement of the biometric values, and the assumptions which go wrong when any of the conventional formulas actually calculate the IOL power. So historically, various methods have been described in literature. Especially these came out in 90s and going up to 2000s, when the primary sources of information were the keratometry and the ultrasonic axial length. This is pre-IOL master era, where optical axial length measurements and ray tracings were available. So you would have things like clinical history method, contact lens method, where you will fit the patient with an RGP lens. I believe some people still follow that method because it gives a very accurate measurement of the anterior surface of the cornea. And then you have various adjustments which were followed. Before the optical biometries, we also used to follow that a very good empirical formula used to be that you follow the conventional keratometry findings, input them into the formula, and then you add 30% over it. And that used to work quite well. It still does quite well if other measurements are not available. So total keratometry was a new concept which combines the telecentric keratometry and swift source OCT for assessment of both the anterior and the posterior corneal curvature. So what this does is that it takes into account the alterations done to both the anterior and the posterior surface of the cornea, and this is what is incorporated in the newer versions of the IOL Master. Then you have recently machine learning based IOL formulas which are being used now. People are using them, have reported very good results, although I have no personal experience with them. Then you have intraoperative measures like ORA, which actually do a wavefront analysis on the table once the lens is out, and you can get an on-the-spot reading of the IOL which has to be measured. These work especially well if you are unable to get any sort of reliable reading in the preoperative period. If we look at literature regarding which formula works the best, we will find that you could have two cutoffs where you could measure success. If you go by 0.5 diopters of IOL surprise in the post-op period, then most of the formulas do tend to induce errors. But if you keep that cutoff at 1 diopter, then you get much better results. But you will find that on one end of the spectrum, you will find all the ray tracing based calculations, and the middle would be the Barrett, so the Barrett's TrueK, which I frequently use, and on the right side are the traditional formulas used with various corrections. Again, this slide, as I mentioned, the dark green represents the eyes following in 0.5 diopters of post-operative error, and the light green incorporates, it goes up to 1 diopter. So if you carry the cutoff at 1 diopter, then most of the formulas tend to do very well. ORA seems to be the method of choice if the readings are not available preoperatively. I'll look at a few of the cases and try to share my understanding and working algorithm. So this is a patient who had undergone RK and was planned for cataract surgery. So the way we look at is that we try to get the measurements from various instruments which we have at our disposal and try to look at comparability across the magnitude and the axis of the astigmatism. If that is consistent across various instruments, then we tend to rely that, okay, the readings are more accurate. If the corneal aberrations are very high, we will, most of the cases, we tend to go for monofocal IOLs. However, if we find that the internal aberrations are higher, but the corneal aberrations are very low, then even multifocal lenses are planned. So if we are planning for a toric IOL, then what we are looking for, as Dr. Tully also showed in one of her slides, if you can make out a bow tie pattern on the astigmatism, and you can get a consistent axis across at least 2 instruments, then you can be pretty sure that of your measurements. And so this patient underwent a toric IOL implantation following this. So this is a patient who underwent LASIK and had a cataract. And again, as I said, the HOA were within normal limits, and the angle alpha was also acceptable. So this patient was planned for a toric multifocal lens. So another patient who has undergone RK but also has Salzmann nodular degeneration and is planned for cataract surgery. In fact, this patient is yet to undergo cataract surgery. And what I want to stress here is that even if you run various formulas, you will find the IOL paths which come out in a range of errors. So what you are looking for is to choose the PAR on the highest possible end of the spectrum. So you want to put the highest PAR which any formula is giving. That would, because the chances of going under are much higher than going over. Despite all our precautions, still we end up with refractive surprises. And as I mentioned in my first slide, these patients really don't want to wear glasses. And so we do need to be slightly more aggressive with these patients in management. So what are the various options? If there is a very small magnitude of error and it's a myopic, another reason for targeting myopia in these cases, these can be managed by a PRK or a LASIK following cataract surgery. If there's a misaligned IOL, it can be quite easily managed with IOL rotation. If there is a great hyperopic error or an IOL surprise, which is quite common, especially if the preoperative evaluation missed the surgery itself, then piggyback lenses are a better option. And if piggyback lenses are not available, or if the magnitude of refractive error is very high, then the final choice is to do an IOL exchange. Although again, this compounds the problem even further, because now the toric IOL also has to take into account the surgically induced astigmatism caused not only by the previous surgery, but the increase in astigmatism which is going to be caused by the IOL explant itself. Last couple of slides where I'll introduce a new concept which we have been working on, the concept of, so this was the original paper on EDOF lenses. So it was interesting that they hypothesized that the EDOF lenses, which they basically work by, so a monofocal lens has a single plane of focus, a bifocal diffractive lens has two planes of focus, but an EDOF lens or an enhanced monofocal lens has an elongated plane of focus. So they said that they probably work better in astigmatism because it spreads out the area of focus itself. So we tried these lenses. We have been trying these lenses in patients who have undergone previous corneal refractive surgery to further give us a cushion for preventing IOL surprises. And we found that although there was no statistical difference, but there was a trend, probably because of the lower sample size, which had these patients had a better uncorrected visual acuity. They did, however, have a much better near visual acuity. And post-LASIK patients did better than post-RK patients. In conclusion, for central corneal power, more than one method should be used. You are looking for consistency of measurements across various instrumentation. Again, we use the Barrett-Struke and the Hegel formula to calculate the power, and we normally go for the higher power which either of the two formulas gives. We tend to err on the side of myopia wherever possible, because even if the myopia is going to be less bothersome, and B, it is still correctable by a future PRK. And we do plan a toric IOL in these cases, but only if the magnitude and the axis of astigmatism are consistent across various instruments. And one has to go an extra mile to counsel these patients to temper their expectations, as they really don't want to wear spectacles. Thank you.
Thank you. So is there any question from the floor?
Can I ask a question?
So that was fantastic talk, and we're seeing more and more of these patients, obviously, and they will keep increasing as more people.
They are increasing because now the LASIK patients are also coming into the pool.
Exactly.
And one more thought, that they're tending to present earlier than the RK patients.
They are.
So probably something to do with either the baseline myopia, which is a risk factor, or something to do with the laser
With the laser itself.
Yes.
I've wondered about that because they are much younger.
And they're harder, and the cataracts are harder than their age. Yes,
exactly.
I'm sorry, the question.
No, so my question was actually about the EDOF lenses, because so theoretically, one of the things that bothers the RK patients a lot is that fluctuation in the vision, right?
Yes.
And the measurements too.
Yes.
You measure them at 10 o'clock in the morning, you'll get a different IOL power than if you measure them at 4 o'clock in the afternoon.
Yes.
So is there any benefit then, besides the meeting the expectation, just so that you increase their range of where they can see?
Okay.
And so doing 2 measurements and then using an EDOF that would hit both those numbers, so that they always...
I really haven't thought of this thing that it might help them, even in the fluctuation.
Right.
The initial thought was, when we read this paper and we picked up the idea from there, was that, okay, so it does give you an extended depth of focus. So even if there is a small, because these are the patients who actually end up with, because now with the current technology, the other patients, we don't touch, we don't see IOL surprises now. It's pretty accurate. It are these patients who want a zero power, and they end up with IOL surprises, paradoxically. So we thought that, okay, it will give us a small, a slightly longer range than normal. And we did see now, after we did this study, now the EDOF lenses have come with toricity also.
Right.
So this is what we wanted to do actually when we started this study. That would have been the ideal comparison which we are starting now, that to compare. So if it offers any addition, the toricity, if you you take toric lenses in 2 groups and add EDOF on top of it.
Right.
Now, if that gives a better sort of range of vision, talking temporally in terms of the time or even in terms of the post-op refractive error,
right,
then it will actually validate that concept that yes, it tends to compensate for a small degree of refractive errors, because we calculated the defocus constant. I did not show those graphs. So you can see that the defocus values, which is that how much defocus you can tolerate. So these patients can tolerate up to 1.5 to 2 diopters of defocus.
Wow.
And that's the range sort of a cushion you are getting against IOL surprises. So it worked in these patients on a small sample size, but the ideal comparison would be with a toric lens with and without EDOF.
Yes. That would be exciting. To next project for you to do,
yes.
Tushar.
Thank you.
Can I ask one quick question? So I believe one of another complication with post-RKI is actually decrease corneal endothelium actually dysfunction.
Sorry,
decrease the corneal endothelium.
Yes.
Epithelium.
Yes.
So I think maybe we can do the cataract surgery, but maybe there are some patients whose actually corneal endothelium is actually significantly decreased. So in such cases, what to do?
So we see patients who have had more than 32 incisions also. And almost the clear part is much less than the scarred part. So a couple of modifications which we do is that we go for quite posterior incisions, almost with a peritomy and scleral tunnels, so that the entry point is actually before the start of any incision. So that's one modification which we do. Second is doing the entire surgery under viscoat, replacing it, replenishing it after a certain set. So we have set criteria we monitor the CDE, the cumulative dissipated energy, and after every certain intervals. So the 10 is the upper limit where we'll replenish the entire thing with viscoat. And the third thing is that the implantation is done not wound assisted but in the bag implantation, so that there is no additional stress so you enlarge the incision slightly so that the cartridge actually opens in the eye and the lens slides slightly directly into the eye without coming into contact with the cornea. And last but not the least, the viscoelastic removal is done by bimanual, not with the IA, because those are the times where you have maximum endothelial cell loss when you come out after the IA. So we keep the chamber at all times.
Thank you.
Thank you.
Okay, thank you for the wonderful talk. Okay, so I would like to invite Professor Bishar Janji. His topic is acute corneal hydrops. Please start your talk.
Thank you. So, Dr. Yamaguchi is not here. So in case you're wondering, I'm not going to talk about IOLs, but we wanted to fill the session, and I want to talk about keratoconus. I don't have any relevant financial disclosures. So when you talk about keratoconus, it's characterized by axial, central, or paracentral corneal thinning and progressive irregular astigmatism. Estimated prevalence can vary depending on where you are, where you practice. It usually presents in the second decade of life, but we've now started to see more patients even at an earlier age, possibly due to better diagnostic modalities. It can present variably. You can have patients who will come to you with changing refractive error, changing prescription on glasses, myopic astigmatism.